So this is the last session before we finish up for the day. So we're just going to go through 3 clinical cases. And I think you guys have had a pretty crazy day. So I think we're actually going to ask you guys some questions as well. But if you need a brains trust, we've got 3 experts here as well. So we have, you've met some of them before. We have Sarah Whitman, who's a GP here in Melbourne and puts Myrenas in. We have Professor Beverly Vollenhoven, who's Head of Gynaecology at Monash Health. And we have Dr. Philip Thomas, who's a gynaecologist at Monash Health as well. So thank you for joining us. Okay. So we're going to start off with Lynn. So Lynn's a 38-year-old who's got a history of heavy periods for as long as she can remember. It's affected her schoolwork when she was an adolescent, affected her tertiary studies, and it restricts her from playing sport. She thought her experience was normal for many, many years. And it was only because she was finding it hard to cover the cost of buying sanitary products that she went to doctors. And they all asked her about her period pain, but nobody ever asked her about the volume of her blood loss. It could have been so much better. So we're now going to work through 3 cases. So case 1 is Sarah. She's 34. She lives in rural New South Wales, for those of you who are joining us by webinar. We're not just focusing on Victoria. She presents to her GP for her cervical screening test, and she mentions that her periods have been heavier and she's been feeling quite tired. And who of us haven't had women present with these symptoms? And her periods, upon further questioning, have been impacting on her relationship and work. So what else would you guys want to know? Just call out.
Iron levels.
Yep, so you'd want to test her iron levels before we stick a needle in her arm. Anything else we might want to know? How often are you changing pads? How long do you bleed for? Nocturnal symptoms? Yeah, if she's been pregnant before and has she had miscarriages and were they complicated with a lot of bleeding? Yep.
I want to know if she's using any contraception, because if she's already on the combined pill and she's still having heavy periods, then it could mean more something.
Yeah. And where is she at in her reproductive life cycle? Is her family complete or not? Experts, any questions you'd like to know?
No, I think I'd do all of that. I think when anyone talks about any period, then I think, okay, what is this period like for this woman? And I think we've mentioned that lots of times, is that a period is more than just pain. And so I think those questions, and I think it's once you know, as Bev's mentioned a couple of times, once you just think this is a symptom and I'm going to ask duration, length, what it's like, what's the impact, you start to just see period as another thing that you really want to explore and get a good picture. I think, you know, I am very lucky. I have longer appointments. I think about that woman in front of me. I would be probably asking a bit more about her fatigue. Yes, anemia and heavy bleeding, really big causes, but I'd be wanting to just check other things. Thyroid, you know, screening for thyroid, diabetes, low mood, depression. They can go hand to hand if you have, and I think as Hayley said, it's very tiring and it can lead with mood changes. And I probably also want to know what she means by relationship. Does she mean sexual discomfort, sexual pain, or just is it that, you know, she's tired, can't go to work? What does that actually mean? Because this might be my only chance to get some of those issues on the table. It might not be the only time I talk about them, but I want to open up those issues so that at some point we talk about them in the future.
Absolutely. Beverly?
I actually want to know how long it's been going on for.
Yep.
It's been a year or 6 months or 5 years.
Okay. So we've got Sarah's more detailed history here. So that all looks, you know, pretty standard. So what would you do in terms of an examination, Sarah?
So I think the first thing that has just pointed out to me is there's a new relationship in the last 2 years for this lady. So with my sexual health screening hat on, I would be wanting to, I'm doing a cervical screening, but I'd also like to think about chlamydia and other sexual transmission of disease, because a change in relationship at any age is a risk factor for sexual health. So I'd be looking for, I must admit, I also would be sort of, before I even decided about that, I'd be looking at the vulva and vagina and the perineum. I think we don't look at that enough in general practice, so I'd probably be standing back a little bit and looking at that. Then I'd be looking for, what does her cervix look like? What does her vagina look like? I'd be definitely swabbing for chlamydia. I'd be doing my cervical screening. I'd be looking for any sort of cervical polyps, and go from there.
Okay. Do you always check for chlamydia before you consider putting an intrauterine device in?
Do you want me to answer that?
Sarah? We'll do a straw poll.
Not always.
Beverly?
Yes, I do, although I've been told by my boss that I probably shouldn't and I'm wasting taxpayers' money. It's so hard to screen them, it's so hard to get an assessment of risk. Also, too, if they question it, you can say, yeah, I always do this is what we do. It's a very cheap test, it can now be done on a thin prep, and if I always do that, then I never miss one.
And if a woman came to you to get her IUD put in at that consultation and she hadn't been screened, would you put the IUD in and take a swab at the time, or would you make her come back?
No, I'd take the swab at the time and I'd treat retrospectively. And there's evidence too that even if women turn up with a positive chlamydia PCR with an IUD, if they're relatively asymptomatic, then it can be treated without removing the IUD.
Yeah, so I think that's a really pragmatic approach, and I think that's great, because what we don't want to be doing is creating more barriers to women getting the services that they need. Okay, so Sarah, you've done a very thorough examination.
I'm now very late.
That's okay, you're a GP, you're always late. So her BMI is normal, her vulva, vagina and cervix look normal on examination, and you notice that she had an anteverted bulky uterus. So what are the differentials that are going through your mind, and what are you going to do next?
So the things that go through my mind is that this may be normal and she may just have a heavy lining, which is normal for her. But I would be wanting to know, does she have, probably in this age group, adenomyosis, but I would be wanting to make sure her endometrial lining is normal. I'd also be thinking fibroids. And so I would probably suggest I'd like to get an ultrasound.
Gee, that sounds like clinical care standard number 4. Well done. Would anybody in the audience be doing anything differently at this stage? No, excellent.
I still want to know how long she's had the problem for.
Let's say it's been 4 or 5 years.
And I'd like to enlarge on the examination. I mean, I don't
Yep.
think I'd go straight to the VE. I think I'd shake their hand first. I'd take their blood pressure. I'd sit them on my little up-downy couch behind my little screen, show them where they're going to have to put the towel over their tummies.
Clearly, as a
Do it
private
slowly.
consultant.
That's right. Get their confidence. Make
Yeah.
sure that the examination means something that is not too tense.
Yeah, absolutely. Actually, it's really important. Like women can feel that they're being treated like cattle in clinics. So it's really important that, you know, when they're in the room with us, that they feel like they are the only important thing happening in our lives at the time. So, yeah, good point. Yep.
I also want to know what medications she's taking,
Yep.
and whether she's taking fish oil.
Yes. Would you like to expand on that?
Fish oil makes people bleed. So if they're taking fish oil, stop it.
They'd be much better off eating their fish.
Absolutely.
Yeah, and I have to say, I love telling my patients to stop taking their multivitamins and spend that money at the greengrocers instead. Okay, so you've sent her off for some blood tests, and her haemoglobin comes back at the low normal range, and her ferritin is low. You initiated some oral iron and tranexamic acid for her next period because you're waiting for her to have her ultrasound on day 5 to 10 of the cycle, and following the clinical care standards 2, 3 and 4, you did actually start some treatment whilst completing her investigations. And this is her this is an example of an ultrasound. So we spoke earlier in the day about the importance of getting a good quality ultrasound and the things that we're looking to see. So the endometrial thickness and the structure of the uterus. Beverly, would you like to make a comment about these 2 images?
So the endometrium, it looks like it's in the proliferative phase
Yeah.
of the cycle. It doesn't look thickened, it looks even. from here.
So this is that thin white
Yep.
stripe through
Yep.
here on the longitudinal, and
Yeah.
this is
And-
looking transsectional.
Transversely,
Yep.
yep.
So looking from this
Coming
way up.
across.
Yep.
The first one. There doesn't look like there's any evidence of adenomyosis or fibroids. There's a comment that the ovaries are normal, but I can't
Yep.
see the ovaries. But
Well, here are some
okay, right.
ovaries.
So she's got a follicle, and she's got a corpus luteum. Well, that's a corpus.
So these
luteum
are
cyst.
4 different pictures of ovaries. So
Yeah.
we've
So the first one's in the proliferative phase. The second one, that one, is after ovulation. So the corpus luteum is the most vascular. Oh, sorry. The first one's a follicle. The second one's the corpus luteum, and you can see there's a lot of vascularity to it. It's the most vascular organ in the body. And the third one, that one, it's resolving, and that's a non-active ovary. So that could be a postmenopausal ovary. It could also be someone who's on the pill, on the oral contraceptive pill.
Okay, and let's keep talking about pelvic ultrasound. So we've got the normal endometrium down here in the proliferative phase, but up here we've got also a normal endometrium, but it's in the secretory phase. So you can see it's much, much thicker. And this is why the timing of the ultrasound is so important, because if you send her off for an ultrasound and you get this, you need to know, is that abnormal or is it normal? And it's all about this phase of her cycle.
So also in the secretory phase, you can see you lose that, it's called the trilayer. You lose that in in the secretory phase.
It's blurred.
And the endometrium doesn't actually thicken up in the secretory phase, so it's at its maximal thickness just before ovulation, and then in the secretory phase, it changes appearance. That's all that happens. It doesn't become any thicker.
And this is a slide that shows some fibroids, and this is a bulky uterus. So I must give acknowledgement to Kirsten Black, who put these slides together as well. Now, you mentioned adenomyosis before. So can you describe the appearance of that uterus?
So adenomyosis is where the endometrium is in the muscular layer of the uterus. So what it appears on ultrasound is they call it a Venetian blind appearance. And it's often worse in the posterior. That's right, isn't it? I'm trying to think. It's often worse in the posterior uterus than in the anterior uterus. So it's that kind of sort of appearance.
This
you can see the
stripy
Venetian
look
stripy
here.
appearance.
Yeah. Okay.
It's very common now. Ultrasounds, well, good quality ultrasounds can pick up adenomyosis in teenagers. I've got teenagers with adenomyosis on ultrasound.
It's kind of one of those nice diagnoses to have, though, because it provides the woman for an explanation and validation for her symptoms, but also it's not likely to cause her any serious pathology, and we can manage it. So I kind of like it.
Not the teenager.
Not for IVF either.
Yes, that's right.
Yeah. Okay. Now, this is Sarah's ultrasound report. So it shows that she's had transabdominal and transvaginal scanning, as is recommended in the Clinical Care Standard. The uterus is leaning forwards, it's in the midline, it's looking quite bulky. So who's got one of those Mirena models sitting on their desk? You know, the uterus is tiny. It amazes me that that's the size of a normal uterus. So this is looking quite big compared to that. It's described as looking bulbous, and the appearance of the myometrium is consistent with adenomyosis. So we've got that Venetian blind appearance. So the endometrium isn't thickened, and it confirms that the scan was done in the correct phase of her cycle. The ovaries are looking normal, and there's no concerns with those. So the conclusion is that Sarah's got a globally enlarged uterus with adenomyosis, and that this may account for her heavy, painful periods. So like most radiology reports, there's always that caveat at the end. So management options for Sarah. Anybody in the room? What would you do? what would you do as her GP?
Well, I would give her the options. She could continue to use transdynamic acid if she wanted to, but it does mean she has to do this every period. But I would offer it to her. I'd also offer her the pill. That might be appropriate for her. She might want something that she can stop or start on her own. Depends on her fertility, what her plans are. But I'd also offer her the Mirena. I probably wouldn't use so much the point there of cyclical northisterone or Depo. I still have used Depo in the past, but because Depo you can't remove if they're having side effects, plus also my concerns about long-term osteoporosis, it's not an option that I don't use. It's probably just one that I use less frequency. I can see she doesn't like the pill, so I've probably already been told no thank you, and I would have said that's fine. And I'm very lucky I can do Mirenas myself in my room, so that's probably what I would offer her.
Beverly?
I think she's a good candidate for a Mirena, but I think the major issue with Depo is that she's young and may want to have children, and Depo just has a delay to return to fertility. It doesn't change fertility, but it has a delay. And she's already 32. She may decide she wants to have children when she's 36, and it may not be till 37 that her periods return. So that would be my issue with Depo.
Philip, anything you'd like to add?
I agree. This has got Mirena written all over it. The two things about her period pain was that it begins with a period and resolves in a couple of days, so it has that sort of flavour of primary dysmenorrhea. She'd probably also do well on proper preemptive non-steroidal anti-inflammatories. Many women take one or two, which is not really enough, and they take it too late before it's all, after it's all turned to porridge. So preemptive non-steroidals and tranexamic acid can be very useful, and some people still prefer that. But I think Mirena would be my first choice.
Yes,
I
Stephen.
would just be concerned that she's had the side effect to the pill in the past, and it's probably due to the progestogen that's in the combined pill that she's had in the past. And Mirena, even though at a much lower dosage, still has progestogen. And if, I don't know if it's evidence-based, but I often ask these patients about PMS symptoms. And if they have quite severe PMS symptoms, which is caused by progesterone, then I still think Mirena is the first line, but I do tell them that there is a chance that you could get the same symptoms again, but I reassure them that you can reverse it quite readily by removing the Mirena.
Yeah, I think that's a good point too, particularly if women are changing from an form of contraception where ovulation has been suppressed. They may well, the majority of women are going to return to ovulation with a levonorgestrel intrauterine system, and some women actually don't enjoy the symptoms of that ovarian cycle occurring.
Can I just say something about non-steroidals? What I tell my patients is right time, right dose, right number of days, because they don't work because they're not taken at the right time, they're not taken as soon as the pain occurs, they're not taken for the number of days, and they're not taken at the right dose.
Yeah, absolutely.
So I think they work if they're used in that way.
Okay. Now we've just got a couple of pictures of some unusual uterine shapes, and I think the point of these is to highlight when can't we use an intrauterine device. Beverly, would you like to comment?
Yeah, so if you have someone who has a septum in their uterus, so what that means is they're born with a division in the uterus, or they've got a bicornuate uterus, which means their uterus is sort of heart-shaped, then you can't use a Mirena because they've got a division in their uterus. So you can't put in two Mirenas, though I have actually seen that done, but it shouldn't be done. So you can't use it. You can't use it in a woman who has a septate or a bicornuate uterus, and you can't also use it in a uterus that is very small or very large. So if a uterus measures over 10 centimetres, the Mirena IUD will float in the uterus and won't be effective.
So this is a picture of the septate uterus, and this is a picture that shows the Mirena sitting up the top of the uterine fundus. So you can see how that just won't work in these uteruses here. Okay, so So we know that intrauterine devices can be inserted in the primary care setting. If you work in a clinic where that can't be done, then you should develop a referral pathway where you can refer to either another GP clinic or a community health centre where that can be done quickly, rather than sitting on a long waiting list in the public gynae clinics. And I think reviewing these women, no matter what medication or management option you've instituted, you need to review them to make sure that it's working, because if it's not, you need to try something else. So we'll move on to Lara, who's 42. She's just started a new relationship. She's got 3 children. And over the last year, she's been having prolonged and heavy cycles. She bleeds for 7 days every 28 days, and she has clots and mild pain. She's feeling tired. You do an examination, which is unremarkable. Now, clearly, this is a bit of an abbreviated example of what happens in practice. What would you guys like to be doing next? Anyone from the floor? Blood tests? Yep. Ultrasound, maybe? Okay. So she has an ultrasound done, and this is what we see. So, Philip, would you like to talk us through this ultrasound?
Yes, so before we saw that lovely, perfectly defined endometrial trilayer, in this patient, she has an ovoid-shaped density within the cavity with probably even a little sliver of fluid around it, and this is consistent with a polyp. And although we can get lovely pictures with saline-infused sonograms, we can often see the same just with pressure on the probe, and they talk about a sliding sign. So sometimes the polyp can actually be seen moving against the adjacent endometrium. And it's obviously quite uneven in its thickness. So from the left to the right, there's a big ovoid mass which isn't present in the bottom of the cavity.
Yep.
That's a fairly decent polyp.
Yeah, and I think this is highlighting that it's likely got a vascular core to it as well. So this is the sonohistogram. So this is where they actually insert saline through the cervix at the time of the scan to dilate the endometrial cavity, and that just highlights beautifully the outline of the polyp here. I don't know if any of your patients have had this done, but it's quite fiddly and it can be quite uncomfortable. It's certainly something you need to have explained to them beforehand if this is what you're referring them for.
So I'd add too, you probably won't get that as your opening scan. So a lot of ultrasound practitioners, gynecologists will not do that unless the patient has had chlamydia screening and probably even doxycycline prophylaxis, and so it needs to be ordered ahead of time. And generally I'll give my patients a dose of doxycycline to take on their way in, or azithromycin. Yeah.
And certainly my experience is that you can't get this at your local corner store radiology clinic. This is generally a tertiary level service.
So similar information to an HSG.
Yep.
In primary care, you're probably just going to get a report saying there is a polyp, and then that would then mean I would be referring to my gynecology colleagues. It's not something that I would be managing in general practice.
Yeah. So it's not uncommon for women with polyps to present with that prolonged heavy bleeding or intermenstrual bleeding. There's no point trying to put levonorgestrone intrauterine system in to manage this. It will not work.
No. You would stop there. Even if you were a Mirena inserter in primary care, the polyp needs to be taken care of first.
Yeah. So this is for early referral, and the woman will be having a hysteroscopy where they'll remove the polyp under direct vision, and then if appropriate she may well have a Mirena inserted at the same time if she's wanting that for contraception or she just wants to avoid menstruation. So case number 3 is Sabha. She's 38, she's had 2 children, no further children are planned. She's married, she's using withdrawal for contraception, which to me would suggest that she's actually actively planning to have another child. She's had worsening bleeding for the last 3 years with clots and flooding, and it's stopping her from being able to go outside on the first few days. So she has a 30-day cycle with bleeding for 6 to 7 days. There's no intermenstrual bleeding and no postcoital bleeding. She has a normal examination. Any thoughts floating through your head?
Yes, my thoughts are that this lady is a lady who she's covered up, and I'd like to know what her vitamin D level is.
Yeah.
For
It's
a variety
low.
of reasons. And that makes me think of fibroids.
So what's the connection there?
Well, vitamin D deficiency and indeed progesterone, yes, progesterone, are cofactors for fibroid growth. And a lady like this of probably Northern African origin who covers up will have a low vitamin D, and they're at very high risk of fibroids. They're often quite big, and they're also at high risk of leiomyosarcoma as well. So that'd be one of my first suspicions.
And your clinical suspicion is proven correct. So she does have intramural fibroids. Now, none of us look like we've been in medical school recently. Beverly, could you just give us a quick rundown on the position of fibroids within the uterus?
Okay, so there are fibroids that are, oh, that sounded weird. There are fibroids that are intracavity, so that means that the entire fibroid is in the cavity of the uterus. There are fibroids that are submucosal, so that means that, so all fibroids come from muscle. So the fibroids that are submucosal may push into the cavity, but also be partly in the muscle layer. So there may be, a lot in the cavity and a little in the muscle, or even etc. There may be fibroids that are totally in the muscle, so they're intramural fibroids, and there may be fibroids that are subserosal fibroids, which means they're mostly on the outside. So if someone's got to have fibroids, the best fibroids to have are subserosal fibroids, because they're the ones that often least cause issues in terms of heavy menstrual bleeding.
Yeah.
Whereas intramural, submucosal, intracavity, in that order, will cause heavy menstrual bleeding in general.
Because they're really distorting the cavity and increasing the surface area, which means there's just more endometrial tissue that needs to be shed. Okay. So she's had the ultrasound that shows she's got the fibroids and they're intramural. And here are some different examples of them. So she doesn't want a hysterectomy, and she certainly doesn't want any hormones. What would you as specialists recommend? Because we've referred her to you.
That was easy.
I'd like to know a little bit more about her fibroids, actually.
Okay.
Their size and their...
They were all about 3 centimetres, and there were multiple. The cavity looked pretty normal. It wasn't particularly enlarged. It was certainly under 10 centimetres, and it wasn't distorted. It was just a big bulky uterus.
Okay, well, with fibroids of that size, there are a number of options. So because there's multiples, it's a little less clear, but with fibroids, it's probably up to 3 or 4 centimetres. A Mirena is still an option, although I've certainly had patients in whom fibroids seem to grow in the presence of Mirena, and again, it's that question of progesterone being a cofactor for fibroid growth, so they can actually make it worse.
And because we're practicing shared decision making, Sapa earlier, she might not have expressed it that clearly, but she certainly doesn't want any hormones. So she doesn't want your Mirena.
Indeed. Okay, the next thing I'd like to know is that does she have pressure symptoms from these fibroids? Does she void frequently? Does she have trouble using her bowels? Does
Not
she have pain with
particularly.
sex? And I'm also concerned that she doesn't use any current contraception, or she's doing very little about it. I'd also want to really clarify her wishes about childbearing.
So she certainly doesn't want any children. If you made a strong case to her that she would have to have perfect contraception for some of the options you'd recommend, I'm sure she and her husband would be amenable.
Okay, well, moving on from there then. I'm doing my best to talk about a hysterectomy. With fibroids of that size and number, look, an endometrial ablation is an option. As you add further pathology, the chance of getting a long-term satisfying result from an ablation does actually decrease, but it's still an option. I guess too, we need to think about what her long-term chances are. So she's 38, I think we said, or 34. 34, okay. She's less than 37. So really, if she has an ablation, even if it works perfectly, she has probably about a 20% chance over 5 years of a hysterectomy, maybe even more because of her fibroids, and therefore there is a chance of retreatment. And some women don't mind that at all, but there is that chance, and that mitigates against the slightly increased short-term morbidity of a hysterectomy. So she needs to be prepared for the probability of further treatment later on.
Okay. And you mentioned earlier, so this is the picture of a... Oh, sorry, Stephen, you had a question or a comment?
Yeah, I think having some of those smaller fibroids, certainly endometrial ablation is an option, but Sapa needs to know that if she has significant dysmenorrhea, then endometrial ablation has been shown to be really effective against heavy menstrual bleeding, but no much effect on dysmenorrhea. And so that could be a precluding factor. And just in addition, she, with endometrial ablation, we recommend permanent contraception. So she'll need to have, now that the Essure has been withdrawn from the market, she would need to have an extra abdominal surgery in the form of tubal ligation unless her husband is okay for a vasectomy.
We'll work on the husband. Okay. So, Phil, you mentioned over morning tea that this is a picture that shows one form of ablation, but there are other techniques as well.
Yeah, they are indeed. So at the end of the day, they all really involve applying thermal energy to the endometrium, so be it via laser. A lot of patients equal laser to diathermy, which is not the case. So laser provides thermal energy, diathermy does, so electrical surgery, or indeed these little hot water balloon devices. So unfortunately she's gone to the wrong gynaecologist because she looks like she's having a balloon device. Balloon devices have a lower medium-term satisfaction compared to the diathermy ones, and they also work not quite as well, and there's a higher chance of failure.
What proportion of gynaecologists would be using that technique now?
I think most people are using what's called a second generation technique. So as opposed to rollerball under direct vision, they're either using radio frequency ablation or thermal balloon. And I don't have any figures in my head about balloons versus diathermy ablation. I suspect that diathermy ablation is a little bit more common, and it certainly has the guts of the market in the States because it's more effective.
Okay. And could you just walk us through this ultrasound of a post-endometrial ablation uterus?
I can indeed. So as you can see, there's really not a lot to see. So whereas before we had that beautiful trilaminar appearance to the endometrium, now we can see nothing. And so this is consistent with an endometrium that's been ablated via conventional diathermy. Happily, the ablations that use second-generation devices tend to preserve the cavity. The front and back walls don't stick together. Rollable ablations work by causing surgical Asherman syndrome, which means that the layers stick together, and so therefore the endometrium can't regrow and it can't shed. The downside to that is that it can sometimes regrow in the corners of the uterus, up in what's called the cornu. If that happens, you can get a collection of blood inside, which causes pain, and in some cases requires a semi-urgent hysterectomy. So, second-generation devices preserve the cavity magically. Rollerballs tend not to.
Okay, thank you. So that concludes the 3 cases that we're going to discuss today. I just wanted to spend the last few minutes talking about where do we go now. So I want to plug this document, which is the Heavy Menstrual Bleeding, the Case for Improvement. There's copies of this on your table and you can download it from the Commission's website. You can just easily Google it. And this is all about, we've got this great clinical care standard, but where do we go now? So we actually need to start the work of implementing it. This document helps to highlight what is known about the evidence, so people always want to know what the data is, and it provides information on what the best practice and current practice recommendations are. It describes in quite a lot of detail what needs to happen to support the implementation of the clinical care standard at the local level, but also at a systems level. And it describes activities that can address some of the barriers that we've talked about today in providing the care as described by the standard. So I'd really encourage you to take this, read it, talk to the people that you work with, talk to the people above you, talk to the local area health services, the public health networks, etc. It's actually got a really quite detailed case example of a PHN and how a PHN can lead the process for implementing this standard within a region. There are some other resources that we wanted to promote. There's fact sheets put out by the Commission that you can use with your patients. RANZCOG has a statement on heavy menstrual bleeding. We know that the department has already spoken today about the Better Health Channel, which is a Victorian Government initiative. We've had Jean Hale's Foundation for Women here today, and we've spoken about the health pathways. In terms of training supports, for doctors working in the rural Victoria, there's grants available through the Rural Workforce Agency Victoria. The details that you can Google those. The other thing is if you've got a GP who is providing obstetric service in rural Victoria, there's funding available through the Rural Procedural GP Grants Program as well. Family Planning Victoria run the IUD training courses for nurses as well as doctors. And the Royal Women's Hospital also has intrauterine device training. You do need to be accredited to be able to access that, and places can be limited. But I think don't be afraid to be innovative in your training. We heard about that great program happening down in Geelong, and Kathy has said that family planning is quite interested in expanding those sorts of partnerships. So let's be innovative and get this happening. So that's the end of my talk, so thank you very much. I'd like to hand over now to Robin Hudson, who's the Director of Clinicians as Partners from Safer Care Victoria. And just before I do that, just a reminder to everybody who's been participating today on our webinar, there will be a CFI link sent to you on Friday. I have that on good authority. So thank you very much.